Good morning, everybody. So I'm going to shift gears slightly, and I'm actually not going to talk about HIV at all. As Linda pointed out, nutrition, which is what I am going to talk about, underpins a lot of the consequences of being HIV affected. So I'm going to take a bigger picture and talk about nutrition generally in the context of the environments in which HIV affected children live. So I take in my work, I take a life course perspective. And to me, childhood is just a stage. And what we really care about is people becoming healthy, productive adults. In order to get there, people have to go through childhood. Some parents would believe that we'd like our children to go through childhood faster. And to do that, they need inputs that are provided by the resources available to the parents and the community. And I'm going to be focusing on food as an input and growth as an indicator of child health. So what is it about growth that we care about? Well, a major study run by the World Health Organization and published in 2006 shows that if you take middle-class families in high and middle-income countries, and you take children born in those families to mothers who intended to breastfeed for 6 months, mothers who didn't smoke, parents who had decent sanitation, etc., and so forth, those children grow pretty much the same around the world. So differences that occur and that we see in the growth of children have to do with factors that are not genetic and are not due to the fact that they are just children, but have to do with the environments in which they live. Being taller is generally thought of as being a better thing. Adults who are taller earn more. In the United States, at least, the taller candidate has generally won the presidential election. There are some caveats with respect to cancer, which is a disease of uncontrolled growth. And on the flip side, relative weight, which is lateral growth as opposed to linear growth, is generally regarded as being detrimental. So what we would love to do is get people to be as tall as possible without increasing relative weight. And I want to kind of have that as a general theme. Growth failure, as Linda mentioned, is a proxy measure for a wide range of nutritional insults and non-nutritional insults that operate through nutrition understood in a biochemical sense. Energy deficiency relative to need, aggravated by infections and the increased burden required to manage at a biochemical level the infections. And even if energy is not limiting, micronutrient deficiencies, because of the needs for those micronutrients in the metabolic processes to process the nutrients into growth, can also impact on attained size. It's very critical to realize that growth failure is something that happens early in life. These are data from the demographic and health surveys, from the recent ones from the early 2000s, published by Cesar Victoria and his group in 2010. This is the Z-score, mean Z-score across countries by month of age for countries in the 5 WHO regions that are covered by the DHS. You'll see in all of them that by age 5, the mean height for age Z-score is below 0. In other words, there is growth failure at some level in all these regions. That the magnitude of that varies. It's strongest in the African region and the Southeast Asia region. And that all of that growth failure happens in the first 2 years of life. Some of it's present at birth. If you look at the month 1 age there, although most people who use DHS data don't trust birth lengths, and is much more kind of by age 24 months, there is no new growth failure. There might be a little bit at some points, but kind of at a population level, that's when it's happening. To think about prevention, therefore, or remediation, you have to think about the first 2 years of life. Does growth failure matter? These are data from the cohorts collaboration that I've had the privilege of working with Linda and others. These are the 5, I know there are 4 here, the 5 birth cohorts in low and middle income countries that have covered substantial numbers of individuals under observation and have reached adulthood. There are only 4 here because these data were published in 2008, and the South Africa cohort, which is one of these, was still adolescents at the time. What you see here is the relationship between height at age 2 years, in other words, after that growth failure has happened, and schooling. And it shows that across the 4 countries, for men and for women, being 1 HAZ unit increase in height is associated with an extra half year of schooling. I use the term associated carefully. I know I'm in the World Bank, and economists don't like to use the word cause. So let's move to some causal modeling done by John Hodnott using data from one of those studies, the one in Guatemala, where he looked at a wide range of consequences of being 1 height for age z-score taller at age 2. 1 height for age z-score at age 2 is about 3 centimeters, just to give you a scale here. So what does 1 standard deviation in height cause? It causes you to be about 0.8 grades of schooling more. Now, this is a cohort which has an average of 4.7. So that's, right, 1 more grade on an average of 4.5. A quarter of a standard deviation of improvement in reading comprehension and in performance on the Ravens test. You have a partner who is older, who is taller, and who has more schooling. All these good things happen with not being tall as an adult necessarily, but being tall at age 2. Okay? If you're a woman, you have a later age at first birth. You have lower fertility and improved survival among the children that you do have. You have a 21% increase in your household expenditures, and you're 10 percentage points lower likely to be living in poverty. So there are major economic, social, and cognitive benefits from being tall. So, can one do anything about it? What benefits can we expect from intervening early in life? So, the Guatemala study was, in fact, a randomized trial. 2 villages were allocated to an improved nutrition supplement offered at the village level, with the intakes being recorded. 2 additional villages, matched on a range of socioeconomic factors, were offered what is essentially a soft drink that did not have protein and did not have a wide range of other possible benefits. The data here are from one of the early evaluations of that program. What we have is the indicator of severe stunting. This is children who are below -3 on a height for age z-score. I would point out that in the United States, any child who is below -2 is a target for treatment with growth replacement hormones and so on. So this is a population with 50% severe stunting in the 1960s. The severe stunting rate was not affected by receiving the control intervention. But children who had received the atole, the improved intervention, for 3 years, in other words, kind of by the time the program had been in place for 3 years, the prevalence of severe stunting had halved. We can reduce severe stunting, and by implication, we can improve overall growth by intervening with food in the first 2 or 3 years of life. Does that matter? Well, back in 2003-04, we went back to those children, and we did a wide range of tests on them. What we have here are on your left is we'll get there. Okay. I'm running out of time. Okay. Basically, the dotted line at the top is the improvement in intellectual capacity on the left, is reading ability on the right, is performance on the Ravens test, stratified by schooling for the kids who got the intervention in the first 2 years of life compared with the solid line at the bottom, which is the kids who did not. Does that matter in the long term? Does performance on a test matter? Well, yes. Those kids who received the intervention early in life earn more. The minimum wage in Guatemala is $8 a day. These kids are learning now as adults, right, are earning an extra $1,000 a year. It's important to point out that it is very difficult to remediate stunting once it has occurred. There's been a lot of effort in school-based nutrition, adolescent-based nutrition. We do not know how to later impact on height. What we do know is that if we give people food once they're already stunted, we run the risk of them becoming overweight. So the time to intervene has to be here, not out here. This line, there is not a global problem of wasting. There are pockets of wasting. There is not a global problem. The solution is not global feeding. So just to summarize on this, child stature is a good proxy indicator for child health and well-being. Most growth failure has happened already by age 2. Food-based interventions work, but they only work if they're given very early in life, and they have long-lasting consequences over the life course. This schema here is just to highlight there are lots of possible nutritional interventions. You give the wrong one, it's not going to work. We don't know in a specific context what the rate-limiting nutrient is. The recommendation, therefore, and based on our data in Guatemala, is you've got to give food. Food has all the nutrients. And just work on getting better food to people, and as Linda would point out, via the families early is the way to go. Thank you.